So this is about upper GI surgery. There are around for upper GI surgeries 482 to 98, roughly 100 pages are there. Out of these 700 pages, upper GI. So let's start with esophageal disorders, rupture of the esophagus. So there are two types of rupture. One is Mallory-Weiss and another is Borevi syndrome. Borevi syndrome. So what is the difference between the two? There is incomplete tear. It is just a mucosal tear, while Borevi is complete tear. So through and through, and most of the cases develop secondary to sudden increase in pathology in Mallory-Weiss is most of the cases sudden increase in intra-abdominal pressure leading to tear involves underlying esophageal venous and arterial plexus. So what does it involves? Underlying esophageal venous and arterial plexus associated with alcohol intake or hiatus hernia or old age. The site is mostly start from stomach and reach to the lower esophagus. So it starts from stomach up to the lower esophagus. Clinical picture is vomiting, retchings, and hematemesis is there. Epigastric pain is there, and investigation is through endoscopy. So these are the Mallory-Weiss tears, and treatment is it should heal spontaneously. Mallory-Weiss tear. So after getting alcohol, there is a bout of vomitings and all that. In that, there is stretching inside the mucosal wall, and that is called as Mallory-Weiss tear. While Borevi syndrome, there is spontaneous perforation. This is perforation of esophagus that results from sudden increase in intra-abdominal pressure. Intraesophageal pressure is increased combined with negative intrathoracic pressure. So pressure inside the stomach, this esophagus is suddenly increased to such an extent that there is perforation pathology. And what is the site is? Here the site is from stomach and reaches to the lower esophagus, while here left posterolateral esophageal wall is common as site 2 to 3 cm from esophageal gastric junction. Clinical pictures same in chest pain, surgical emphysema may be seen, udinophagia and septic shock. Person may go in shock. Chest X-ray shows pneumomediastinum. So this is the diagnostic. There is air in the mediastinum, pleural effusion. CT is the best investigation in this. CT has to be done. CT scanning is done as best investigation. Or contrast esophagoscopy, esophagography, which is it should be gastrography, not barium. It is a water soluble. So contrast. It needs surgery. These are the two different types of rupture. One is Mallory-Weiss mucosa and Borevi third. So esophageal rupture due to iatrogenic when you try to do esophagoscopy and all this perforation of esophagus damage considered treated without surgery. Total parenteral nutrition. In this, whenever esophageal perforation, you have to go for parenteral nutrition till it heals. CT scan is best for diagnosing esophageal injury. CT scan, not endoscopy here. Endoscopy can be done only in Mallory-Weiss tear. So motility disorders, this is loss of effective. What is this? Is motility, movement on the esophagus, loss of effective esophageal peristalsis, and failure of this is esophagus, and it is opening into stomach, and this is the lower esophagus, this stomach and the pylorus. So this is called as lower esophageal junction. So there has to be peristaltic view from there and relaxation of this LES, lower esophageal sphincter, that needs to relax, resulting in impaired esophageal emptying. If it doesn't relaxes, so emptying will be difficult and gradual esophageal dilatation. So this is going to dilate slowly. This is achalasia. It is most commonly primary esophageal motility disorder. Etiology is unknown. Dysphagia for liquids. So solids, because of weight they can pass. Initially there is dysphagia for the liquids, then regurgitation. Whatever liquid they may come back. There is weight loss in the patients. Investigation is dilated esophagus with narrowing of the end. That is called as bird beak. So this is like this. Lower is narrowing. This is called as bird beak appearance. Lack of peristalsis. There is no peristalsis on esophagogram. So you give the barium swallow or barium something and take the X-ray. You see bird beak appearance. Peristalsis not seen. Gastric bubble. So it has to go into the gastric bubble has to be seen. So it is also absent. Mega esophagus in late cases, dilatation will be there. Manometry gold standard, esophageal manometry to diagnose the eclasia. Eclasia endoscopy is done to see it. What are the different types? Now different treatment options are there. Medical, you have to give nitrates, calcium channel blockers, botulinum injection sometimes. Then if what are the other different endoscopic, there are different dilatation given done, and surgeries, Heller's cardiomyotomy or modified Heller's. Not to be in Chagas disease, it is infectious disease caused by trypanosoma cruzi. It is described to damage the enteric motor innervation, leading to megaesophagus, megacolon, eclasia of the cardia. So this was about eclasia cardia. Dilatation is there. There is a medical treatment initially. If not diagnostic, then you have to go for dilatation through endoscopy and surgical repair. So coming to next topic, it is Barrett's esophagus. Barrett's esophagus is a condition characterized by metaplastic transformation. This is metaplasia. Squamous esophageal epithelium. What is the type of? It is squamous esophageal epithelium to columnar type gastric epithelium with goblet cells. This is the question. Goblet cells, columnar means glandular type of epithelium from squamous to columnar. Barrett's is identified up to 12% of those undergoing endoscopies. So investigation follow-up, how to do a biopsy has to be taken, that is coordinatic biopsy, 2 to 3 centimeter intervals must be adequate. Then now what is the endoscopic evidence of columnar? So if you see columnar lining epithelium esophageal biopsy has to be taken, you see different types of glandular metaplasia with dysplasia. Now what is there? If it is dysplasia indefinite, repeat endoscopy, esophageal offers 6 months. Then if you get definite follow up, low grade dysplasia or high grade dysplasia. No definite dysplasia, follow up. If low grade dysplasia, 6 months after you have to do endoscopy. If high grade dysplasia, multi drug treatment has to be given, endoscopic therapy has to be done. What is the treatment for dysplasia? Long-term proton pump inhibitors are to be given. Consider pH and manometry. These are the two tests. In younger patients who may prefer to consider anti-reflux procedures. So this anti-reflux. A regular endoscopic monitoring more frequently if moderate. You must consider endoscopic mucosal EMR. This is called as endoscopic mucosal resection. In cases of high-grade dysplasia. In case of multifocal high-grade dysplasia, you must go esophagectomy. Multifocal, there are more than one sides, then you have to go for esophagectomy. Now, esophageal cancer, coming to this, the commonest risk factor is tobacco and alcohol. Disorders, Barrett's esophagus, GERD, H. pylori infection, tylosis, Plummer-Vinson syndrome, they may lead to adenocarcinoma. Barrett's, they already turn into columnar, that's why you have eclasia. Eclasia, you get squamous cell carcinoma. Eclasia, squamous cell carcinoma. Barrett's, you get adeno. So human papilloma virus infection may cause esophageal cancer. Pathology, the most common type, squamous cell carcinoma, as you have seen, it's in the more common is squamous cell carcinoma. This Barrett's esophagus, you get this is less common. Upper 2/3 cervical, upper and middle third of the thoracic. So these are different sites. Which location? Upper 2/3. It includes cervical, upper and middle third of the thoracic. Predisposing is eclasia. Barrett's is different. Barrett's is for the adenocarcinoma. So adenocarcinoma is seen less common, lower 1/3. It is in lower part, and squamous cell carcinoma is on the upper part. On the top of Barrett's, you get history of GERD. Progressive dysphagia is initially swelling for the solids, then liquids also person get dysphagia, odynophagia, and dull retrosternal pain, weight loss, symptoms of local invasion, distant metastasis. Investigation for diagnosis, esophagogram, barium esophagogram must be initial study in any patient with dysphagia. It shows apple core lesion. This lesion is called as apple core lesion. Endoscopy and endoscopy guided biopsies can be done. So biopsy and histopathology. CT scan of the chest and abdomen, pelvis to rule out any secondaries. Endoscopic ultrasound is done. FDG PET to rule out any other malignancy in any other part of the body. Sure diagnosis for esophageal cancers. Oh, how can you diagnose 100% clear diagnosis of esophageal cancer is squamous cell carcinoma. If you get, and what is the treatment? Chemotherapy is the first line of chemotherapy. So maximum chances of squamous cell carcinoma is there. You have to go for chemotherapy. Sure diagnosis of cancer esophagus, adenocarcinoma. Now it is localized TIS, carcinoma in situ, or limited to mucosa. EMR, endoscopic mucosal resection. If it is having T1 to T3, surgical resection, preoperative chemotherapy, metastatic, you have to go for stenting. Surgical measurements, there is depending on the site of the tumor, junctional esophagus, transhiatal or abdominal. So it is at the junction. So abdominal incision has to be taken. Middle and lower one third, 2 Ivor Lewis for the middle, abdominal thoracic. Upper one third, McNeon laryngoesophagectomy, abdominal and thoracic cervical. So, what is palliative management? The presence of distance metastasis, distance disease in esophageal cancer. Further staging is not needed. Surgery is not an option. Esophageal stent has to be placed. Self-expanding metallic stent considered if treatment of choice, occluding tumor more than 2 cm cricopharynx muscle. Cases of dysphagia, metastatic combination chemotherapy improved. Photodynamic therapy, ethanol injections confirmed. So this was about CA esophagus. Now dysphagia. Difficulty in swallowing is called a dysphagia. It can be extrinsic compression from outside, mediastinal masses, cervical spondylosis, pharyngeal pouch. It can be inside the wall, achalasia, diffuse spasm, hypertensive lower esophageal sphincter. Intrinsic tumors, strictures, esophageal web, that is called as Plummer-Vinson syndrome. Esophageal web and short scarring is a mucosal ring, mostly as a reaction of reflux. Short scarrings. This is as a because of reflux. So esophageal infection, neurological, cerebrovascular accident, multiple sclerosis, brainstem pathology, myasthenia gravis. All the patients require upper GI endoscopy unless there are contraindications for this. Note to be for endoscopy, motility disorder may be evaluated by undertaking fluoroscopic swallow studies. Full blood count has to be done. Ambulatory esophageal pH monitoring. You will be required to evaluate achalasia. pH monitoring, that is ambulatory pH monitoring. Approach to reach the cause. What is the cause of dysphagia? Medical history, difficulty initiating a swallow, associated with coughing, choking, nasal congestion, oropharyngeal dysphagia. Sensation food getting stuck into the esophagus second after initial swallow, esophageal dysphagia. Solids or liquids or only solids, that you have to see. Patients develop dysphagia with history of peptic ulcer. So there can be peptic ulcer with leading to peptic stricture, need to be investigated to exclude malignancy. History of epigastric pain, dysphagia, patient develops malignancy on top of Barrett's esophagus. So that is again Barrett's esophagus conversion of the squamous to this columnar goblet cells. So that is leading to adenocarcinoma. History of radiation, post-radiation, long history of antibiotic esophageal candidiasis. If the person is getting history of tracheoesophageal fistula, benign stricture, history of anemia, Plummer-Vinson syndrome, dysphagia to fluids more than solid, achalasia, dysphagia to solids more is malignancy. Management of esophageal stricture, repeated balloon dilatation than if failed endoscopic stent segmentalization. Patients with esophageal stent, if patient dysphagia, they is out for stomach stent migration. So coming to stomach, now this is finished about, we have finished about esophagus. Let's go for the stomach. What are the malignancies? CS stomach. This carcinoma stomach, most common in Japan, less common in Western countries, most common in men and increasing age. Pathology is type of adenocarcinoma. So adenocarcinoma, CS stomach is adenocarcinoma. For diagnosis, staging, what or how for diagnosis, whether staging, complication, preoperative preparation, follow-up. CT scan for chest, abdomen, and pelvis, first line investigation. Then laparoscopy may be done to identify occult peristal metastasis. PET scanning, chemotherapy, pre and post-operative. Endoscopic submucosal, it is limited. Surgery not for now. All the details of surgery, partial gastrectomy, it's not for the exam, so it's not much here. Reconstruction with anterior gastrojejunostomy will not provide anterior Optimal, so Ru and Y is the best option. Cancer stomach is most common GI malignancy present with iron deficiency anemia. So there is deficiency of iron because intrinsic factor is deficient, so it cannot be, so iron cannot be absorbed properly. So that is leading to iron deficiency anemia. So what are bariatric surgeries? Bariatric surgeries and basal BMI, body mass index is more than 40, or if just single 40, more than 40 is BMI, or 3540 kg per meter square plus other significant type 2 diabetes mellitus. 35 to 40, it is not 3540, it is 35 to 40 kg per meter square BMI. This is above 40, that is single indication. 35 to 40 plus diabetes mellitus type 2 and hypertension, that could be improved. So what is a nice guideline? All non-surgical measures have failed. Initially you have to see whether normal non-surgical measures have failed. Beneficial weight loss at least 6 months. It should, so all non-surgical methods should be tried, and clinically beneficial weight loss in 6 months you have to try. They are generally fit for, the patient should be fit for anesthesia, commit to need for long-term follow-up. Person should be followed up for long term, will receive intensive specialist management, or early start may be used for long waiting list. If the person is on waiting list, you have to give for them early start. So these are about nice guidelines for bariatric surgery. Surgical options. What are the other surgical options? Gastric bands, it was previously used. Laparoscopic gastric placement or adjustable bands around the proximal esophagus. Then gastric bypass. Combine changes to reserve size, reservoir size with malabsorption procedure for more enduring weight loss. Sleeve gastrectomy, resection of the stomach along with the stapling device. So it contains advantages of gastric band is it is very easily adjustable. It can be done, disordered long. It doesn't achieve the targets. Maybe erosion and slippage. So gastric bypass is done. This is Ru and Y. This you are clamping and cutting and then you are making a pouch which is small, and it has to be, this Ru and Y has to be attached here. So whatever foods are passing is directly, and this is the lymph for the duodenal pancreatic secretions. Best result in the weight reduction is Ru and Y. Technically, it is more challenging. Risk related to anastomosis leak is 2%. 50% may become vitamin B12 deficiency. So sleeve gastrectomy, this is the sleeve of the stomach is removed. Here the ghrelin cells, they are excised. So less popular now, initial promising results are not found. That's why it is becoming less popular. Post-gastrectomy complication. What happens post-gastrectomy? Syndromes may vary depending upon whether total or partial. Ru and Y gastrectomy generally gives best functional outcomes. If patient has anterior and posterior gastrectomy, complain from any of the following complication, proceed to Ru and Y. Following may be the following gastric complications which should small may occur following gastrectomy. Dumping syndrome is early. It occurs because of hyperosmolar fluid, hyperosmolar load rapidly entering the proximal jejunum. Osmosis drags the water into the lumen, results in lumen distension and diarrhea. So early there is diarrhea, and late there is excess insulin secretion also occurs and results in hypoglycemia, and patient get the symptoms. So it may lead to gastritis because of bile, afferent loop syndrome, efferent loop, and vitamin B12 deficiency. So coming to upper GI bleeding, what are the causes which may cause upper GI bleeding? Characteristic of bleeding is hematemesis. Upper GI, the person is got hematemesis, melena, hematochezia, brisk bleeding. This upper GI may lead to melena as well as hematochezia. So what are the common causes? Esophagitis. It is an infection, small volume of fresh blood, often streaks volume, usually history of antecedent gastroesophageal varices. This is stigmata of chronic liver disease, gynecomastia, portal hypertension. Then Mallory waste, these are mucosal tears, back pain, severe vomiting, okay. Cancer of the esophagus, then a patient may have vomitings. These are the esophageal causes. And what are the gastric causes to lead to upper GI esophageal bleeding? Upper GI bleeding, then upper abdominal pain, worse with eating. Gastric ulcer is immediately after eating you get pain. Small low volume bleeding is more common, so that tend to iron deficiency anemia. Diffuse erosive gastritis, usually hematemesis and epigastric discomfort. Usually it is associated with NSAIDs, diffuse lesions, no prodromal features. AV malformation is there, quite considerable hemorrhage and may difficult to detect endoscopically. Gastric cancer, anorexia, epigastric pain, weight loss, gastric outlet obstruction, palpable mass is there. What are the duodenal causes to leading to upper GI bleeding? Patients with duodenal ulcers usually have a history of epigastric pain that occurs several hours after eating. So, improved with eating suggests the duodenal ulcer. Dyspepsia, duodenal ulcer pain is improved by eating. They are more frequent located in the first part of duodenum. Anteriorly sized ulcers may perforate and result in peritonitis. Post-acid erode gastroduodenal artery and lead to hematemesis and melena. Autoenteric fistula, mostly in the patients with previous abdominal aortic aneurysms, back pain, severe pulsatile abdominal mass with abdominal brute. So, management of upper GI bleeding. Patients having bleeding from the upper GI tract, on how you are going to manage is admission to the hospital for monitoring. Now, immediately the person needs admission, cross match the blood, check for full blood count, liver function test, upper endoscopy and clotting, urine examination, clotting. Early control is important. Plan of the treatment, hematemesis. If there is hematemesis or melena, you just find out hematemesis, unstable, severe bleeding, then research the patient for emergency upper endoscopy, consult surgery or interventional radiology in order to understand where is the site of upper GI bleeding. If cannot be performed, patient cannot be stabilized. Upper GI endoscopy as soon as patient is stable. Then hemodynamically stable patient, upper GI endoscopy within 24 hours has to be done. Special consideration in case of esophageal varices, patient with suspected varices should receive telepressin prior to endoscopy. It should be band-aid or subject to sclerotherapy. These are tests to stop. If this is not possible over to acute bleeding, and then Sengsten Blackmore tube has to be passed, Minusta tube. Then beta blocker usually used in case of beta blockers are basically used in the case of non-bleeding varices. In cases of bleeding varices, ulcers, identifiable bleeding point should be receive combination therapy of injection of adrenaline. Injection of adrenaline has to be followed by thermal or mechanical treatment has to be given. Then hemostatic clips can be applied if failed laparotomy under suture of the if failed surgical resection has to be done. Malarial VST typically resolved spontaneously. So this was upper GI bleeding, lower GI bleeding. Colonic bleeding is most common, typically present with bright red color. Colonic bleeding rarely may be melena, and it's because blood in the colon powerful laxative and rarely retain long is transformation due to 50% of the patient, 15% of the patient with lower GI bleeding will have upper GI source. Then, as a rule, right-sided bleeds tends to be present with darker color, and left-sided is more brighter color. The causes are colitis, bleeding by the brisk and advanced cases. Most often the fever is colon. Diverticular disease is not complete of a major bleeding. Diverticular is often occurs sporadically. Bleeding is often dark and large volumes. Colonic cancers may bleed and patient signs of disease. Hemorrhoidal disease, bright red color occur post defecation. Angiodysplasia, AV malformation. Like Diffloy syndrome, here there can be angiodysplasia. How is the management? Correction of the hemodynamic. First of all, you have to correct hemodynamic compromise. Then in stable patients, standard procedure would be colonoscopy, elective setting. In unstable patient, usual procedure should be CT angiography. Unstable. Stable is colonoscopy. Unstable is CT angiography. Hemorrhagic when suspected proctosic monoscopy has to be done. Surgery selected measures embolization if life threatening. A source of colon bleeding is unclear. Perform laparotomy and tabalic colonic lavage and follow. A blind subtotal colectomy is most advised. Small bowel atrophy fistula may be treated manual. A patient with ulcerative colitis or significant hemorrhage land, so ulcerative colitis, typically medical management is not effective. So this was the part upper GI bleed, stomach and all that. We have completed up to this.